Hello, everybody. We're going to go ahead. Ooh, that's loud. I sound really, really loud. Hello, everybody. We're going to go ahead and get started. This is our public health emergency updates and unwinding of the PHE presentation. First of all, I want to introduce myself. My name is Brian Dowd, D-O-W-D. I am the Deputy Executive Director over Policy, Operations, and Compliance at the Department of Community Health. Which is just a fancy way of saying I'm the policy guy for DCH, member eligibility policy, as well as medical policy and what we pay for and don't pay for out of Medicaid. I really want to thank everybody for being here. It's great to see people again. I've been doing so many webinars and things over Zoom that it's really putting me in a good headspace to actually talk to people in the halls and after presentations. I also want to introduce Rebecca Duggar. She is also one of the Deputy Executive Directors at the Department of Community Health, and she'll be speaking to you all in just a second. She'll give you her title. I can never remember everybody's title. But you got two of the four. So two of the four of Lynette's direct reports are here with you today, so thank you for joining us. And thank you for everybody who's online too. I'm not singling out the people who are here that I like them more, but I like them slightly more because they're here. Okay, so the mission of the Department of Community Health is to provide affordable, quality health care through effective planning, purchasing, and oversight. I always like to give our mission statement before we get started in a presentation. So what are we going to go over today? First of all, we want to do some housekeeping updates for you. We want to let you know, and I just came from another presentation, an EVV presentation, and we want to let you guys know that these presentations are posted on the GAMIS website. So I've seen several people taking pictures and like furiously trying to write stuff down. You don't have to do that. You can if you want to, but you don't have to, because these presentations, just like you'll see them today, are available on the GAMIS website, so you don't need to worry about that. So what are we going to go over today? We're going to talk about member eligibility and dive in a little bit more to what Lynette talked about if you were here in the opening session about some of the upcoming things we're going to be doing with member eligibility. We're going to give a quick Peach Care for Kids update related to that as well. And we're also going to let Rebecca, who's our expert on telehealth, talk about telehealth. Then I'll talk a little bit about vaccine and treatment guides. So to start with, the public health emergency was declared in March 2020. Does everybody remember those good times way back then when we were all like, what do we do? Just stay in our house, I guess. And part of that public health emergency, one of the things we had to do as a state to receive enhanced FMAP is ensure that no member was terminated from Medicaid unless they moved out of state and let us know they moved out of state. They passed away or died, of course. We wouldn't keep somebody on Medicaid who died. If the member were to call us and say, hey, I don't want Medicaid anymore, I don't want to be on Medicaid for whatever reason, we would accept their statement of voluntary closure and close the case. That does happen every now and then, like less than 10 times, but it does happen. And also, the Centers for Medicare and Medicaid Services made it very clear that if we put somebody on Medicaid in error, that we should go back and then take them off Medicaid. They should not stay on because we put them on in error. Now, those are the only 4 reasons we're terminating somebody from Medicaid. So as you can imagine, the rolls have grown and grown and grown. And as you saw earlier in the opening presentation, we're up to 2.7, more than that, million Medicaid members at this point. So we have a lot of people on. I know that's been a big benefit to providers because they haven't had to be as worried about all that checking eligibility at the start of every month and making sure that their members were still eligible. I know you guys probably still do that, but it has allowed us to maintain eligibility for our members. So during the unwinding, we have sent in a lot of waivers to CMS for all kinds of things. And they've requested that we have a comprehensive plan for closing down after the public health emergency. We do have that information available. It is on the DCH website about what our plan is. As Lynette said this morning, as it relates to eligibility, we plan on reviewing everybody's eligibility record within 14 months. So we are going to align the eligibility with Specified Nutrition Assistance Program, or SNAP. For those of you who didn't know what SNAP was this morning, it's just food stamps. Those of you who are old like me remember when there were actual pieces of paper that go with food stamps. They weren't really stamps, but they were little coupons. But they changed the name to SNAP several years ago. So we're trying to align those review dates so it's easier for the member, really. The member won't have to do a review in January and then turn around and do a review in March. Once the public health emergency ends and we go through that 14 months, we have to look at all aspects of eligibility. So, just to be real simple, a pregnant woman needs to either be pregnant or in the new 12 months of postpartum period that we recently got approved to maintain eligibility, right? Children have to meet the income guidelines based on their household. If you are an age-blind and disabled Medicaid member, we look at your income and your resources. So we may look at how much you have in your checking, savings, CDs, stocks, bonds, and secured notes to make sure that you maintain eligibility for those programs. Again, we are looking to redo all redeterminations in 1 year. It is very, very important that members ensure that their address is updated. You may have heard about the incentive payments for members to go in and update their address in the system. Some people, I just want to do my own personal spiel here on this. Some people are granted eligibility as a recipient of supplemental security income. They're determined disabled at the federal level. Their eligibility comes from Social Security. So it's important that if you know somebody who's receiving SSI, supplemental security income, that those people make sure that their information is up to date with the Social Security Administration. I really also, at the end of the eligibility, because I'm a little fearful that providers have forgotten this step. The Medicaid manual in Part 1 policies and procedures actually requires you to check member eligibility before delivering services to ensure that the member is still eligible, and if they're in a managed care plan, that they still maintain their managed care plan status. Now, I know many of you guys don't do that because it's just a lot of work, but at a minimum, you should be checking the member's eligibility at the start of every month or when you see them the first time within that month to ensure that they have maintained member eligibility. Again, we haven't terminated anybody yet, but as we move through the public health emergency, we will start to see that churn again where some people come off and come on. We're hoping to minimize it as much as possible. Okay, I'm gonna pause here because I know a big part of the unwinding for everybody is telehealth. So I'm gonna turn it over to my telehealth expert, not mine, but the department's telehealth expert, which is Rebecca. Thanks, everybody.
Thank you so much, Brian. Again, I am Rebecca Duggar. I am the Deputy Executive Director of Eligibility and Enrollment. And so to kind of put that in a space where you can understand our various roles, what Brian just talked about was policy and compliance. I am actually over the operational part of it. How does that happen? How do we fix the system to make sure that members are enrolled, that providers are enrolled properly, and all of those actual tangible things that we have to do. So what I want to talk to you all about today is telehealth, and we know that that is something that's a very hot topic in the Medicaid world. It's something that we have found to be a very useful tool here in Georgia, and so we'll go over those things that we are able to do here in Georgia because we have gotten a lot of comments and questions around various procedures and things like that. So for those who are new, our new providers, of course, we'll do some definitions as well. Apologies if this is redundant for those of you all who have been with us since even before 2020 when we also had telehealth. But it is a use of technology to deliver healthcare information. CMS did provide guidelines to us around what type of telehealth, particularly the modalities that you can use with telehealth. It's not just you calling on the phone. It does include some actual work that the providers have to do, and we'll talk about that. Now, parity. This is very important here in Georgia. Unlike other states where a provider is reimbursed maybe a portion of the rate because they're performing telehealth, you actually get the same rate as if that member was there in the office and you're rendering services. So when we talk about parity as far as our rates, that means that we're balanced. It's equal. Let's see, does this go forward? Oh, let's see. Nope. Okay, so why is it of increased interest? Because one, it addresses barriers to care, including insufficient provider supply. We know that we are at a provider shortage across the board. This allows us to be able to serve more members with fewer providers as we begin to consistently build up our provider pool. You can be in the comfort of your home, they can be in the comfort of their office. You don't have to worry about travel, and that's one of the transportation barriers that telehealth addresses, as well as some of the rural access challenges. We know in the rural parts of Georgia, it can be very difficult to get to some of our providers, particularly those in the specialty areas. So telehealth addresses all of that. And then there's a behavioral health stigma that telehealth helps address. Because you're not going into the office, other people may see you in that office and all those sorts of things. You can be in the privacy of your home with your provider, having those discussions around behavioral health challenges. So telehealth was very useful as we moved forward with that. Now again, as I said, telehealth is not new in Georgia. This just provides a little history in terms of the Georgia Telemedicine Act. That's actually been in place for quite some time, and you can go out and read the entire act. And then one of the things that we were able to do in 2014 is we were able to do the practice through electronic or other such means, and that was through our composite medical board regulation, and you can also go out there and read that. And what that allows us to do is it allows us to establish the minimum standards of practice. We had to put some framework around that while providing treatment and or consultation services. So we wanted to make sure that there was some standardization around providing this type of care, because we didn't want one provider doing one thing and another provider doing something else, and it just didn't align from a quality standpoint. So, of course, CMS has provided us with guidance. We were not required to submit any kind of state plan to pay for those services, as again, because we're parity, you're providing services and you're reimbursed at the same rate. And again, same manner as when the service is furnished in a face-to-face setting. That is very, very critical as we perform telehealth. So, let's talk about now telehealth in the space of the public health emergency. Now, what you see here, and I'm used to doing that, but in any event, what we had to do is we had to quickly shift gears. We scrambled around, and I think we got on calls every day with our partners to talk about telehealth and to get our systems ready to go. And one of the things that we had to do during the public health emergency is that we had to loosen some of the privacy regulations, and CMS assisted with that, with removing some of those Office of Civil Rights HIPAA violations that would have been in place with some of the telehealth methods, allowing phone visits to qualify as telemedicine. Again, historically, you weren't able to do a FaceTime and that sort of thing. Look at the types of clinicians that were able to practice across state lines. We were able to reach out to our provider community in some of our neighboring states and have them come and practice here in Georgia. That was very critical, again, because we had shortages. Also, allow members to be serviced in their homes. Before, you could only be serviced at certain sites, or you had to go to what we called hub and spoke. You may have gone to a particular site, let's say it was a clinic, and you had a big machine, and you would sit in front of the machine, and the provider was somewhere else at the spoke site, and so on and so forth. You didn't have to do that during the public health emergency. You could receive services in your home. And of course, waiving the need for a pre-existing relationship. Before, you had to already go to the physician, or the clinician. You already had to be an established patient. They already had to have records and things like that on you. But during the public health emergency, we knew that some of these opportunities for engagement were going to be first-time visits. And so that was relaxed so that we could make sure that everyone was covered. And then, of course, expanding telecommunications infrastructure and ensuring that the health workforce could meet the demands. And so that's why it was very important for us to allow some of these other modalities. So, again, CMS significantly expanded the list of covered telehealth services. I mean, they really expanded. It used to be just a small segment. It also included our FQHCs and rural health clinics that they could serve as distant telehealth sites because some folks didn't necessarily have what they needed to even have a telehealth visit. They could go to their local FQHCs or the rural health clinics and be served. They could go into the emergency departments and do a visit. They also, the initial nursing facility and discharge visits. Those assessments could be done using telehealth, as well as home visits. And one of the things that we've always found interesting are our therapy services that could also be performed via telehealth. We always thought it was very interesting. How do you help a member doing occupational or speech therapy by just kind of looking at them and then giving them instructions? But it was still allowed, and we're still working through that particular service. So again, the other thing that we wanted to point out here is that we had to do temporary policy changes during the pandemic, and this is where Brian's shop comes in. We had to go in and make sure that our policies aligned, that from a compliance standpoint, everything that we were doing from a telehealth standpoint was in place. And some of those changes were to conduct telehealth with patients located in their homes and outside the designated rural areas, because historically you could not do telehealth. If you were like in an urban area or the metro area, you had to be in a rural setting in order for telehealth to be reimbursed. Practice remote care, even across state lines through telehealth. That is something we had to make sure was in policy, as well as deliver care to both established new patients through telehealth, and we just talked about that, as well as bill telehealth, both video and audio only, as if they provided it in person. And so we had to also go ahead and set up coding for that, and that took a very heavy lift. And Brian's team was very instrumental in making sure that all of the codes that were impacted, you were able to bill for those codes. And so what does that look like from a provider standpoint? So of course, the services must be a member-initiated appointment. And I know that seems odd, but guess what? We had some folks, and again, you saw in our initial mission statement and oversight, we've seen where people were just calling folks and attempting to bill and saying, oh, I visited with this particular member. Well, that was not allowed. We had to make sure it was in policy. But from a reimbursement standpoint, it must be a member-initiated appointment. and indicated in the treatment plan before services are rendered. So this should just be the regular course of doing business. It's an annual visit, it's a 90-day follow-up, those sorts of things, or even an initial visit. It can't just be where you're just calling, going down your patient list and just making calls and trying to bill us for a visit. And then once that visit is completed and you're beginning to bill, you have to bill in a very specific way. Providers were instructed, and you're still instructed, to use the point of service of 02 or 10. Now, initially we had 02, that allowed all of the codes to be rendered via telehealth that we identified. But then in October of last year, we were notified from CMS that we could use 10. And we had to go back and change our systems, and I think we got it in May. Of May of this year, we were able to update the system to use 10. And so it's very important that we stay on top of that, because if you don't use these particular place of service codes, your claim might deny, because those edits and audits that we put in place, those are still there. Those are still there. So be very mindful to make sure that those place of service codes are there. Now, the codes that were already allowed prior to the public health emergency for telehealth you would have used your GT, GQ, or 95. Those still remain in place as well, because I know we already had codes, so just be very mindful of that. So that's kind of historically, where we're coming from and what we've done over the past 2.5 years. But now that we're beginning to unwind, what does that mean? Where do we go from here? How do we get back to a sense of normalcy? So here's the thing, not really. So one of the things that we did, I think when we initially thought that the public health emergency was going to end a little sooner, we conducted a survey. That particular survey went out to providers, it went out to members, it was on our public-facing side of our website, and it was asking very pointed questions about what you would like to see come out of telehealth after the public health emergency. More specifically, what provisions should remain. So these are things that Brian's group would then understand, okay, I need to maybe put that in policy, and we're going to keep it there. What worked as a provider and as a member, what didn't work, because we're all working through this. We need to know what didn't work and how to fix it, and then anything that we may have missed. Again, as we move through this process, and we've heard from other states, we've heard from other provider associations that will come back and say, this is really what the association would like for you all to do, and those sorts of things. And we take all of that into consideration. And so this is what the survey told us. Everyone agreed that it is a very useful tool when it's applied correctly, which I think is probably what all of that happens when it's applied correctly. So it's also very important for the state to continue to use telehealth. You all have found that it's a very useful tool to meet our members' needs. And to do so, it has to be clinically appropriate. And then, of course, establish or refine those protocols. Now, of course, the OCR HIPAA requirements, that we have no control of, but certainly once we get that information and that guidance, then we will make sure that from a policy perspective, you have that information as well in terms of what you can and cannot do. We also heard about health and safety requirements. You all felt that, this helps my staff. I can remain safe. The members can remain safe because you're mitigating and lowering the rate of any sort of transmission and that sort of thing. Exclusions to the service. We, as an agency, really need to make sure that we're not excluding any service that potentially could be provided via telehealth. And then, of course, the ability for all members and providers to participate. And one of the things we heard is that not everyone has either bandwidth to even conduct the visit. They may not have the various tools, whether it's a laptop or even a phone and some other things like that. So we've heard all of those key takeaways. So again, we talked about GAMIS system and how we've updated it. And so for clarification, that point of service or place of service 10 is specifically a client is in their home. Not a hospital, not a nursing home, not any other type of facility. They are actually where they reside, and the member and the provider calls the member to conduct the visit. Whereas the O2, the particular member can be located somewhere else. They're not in their home. They may be at another doctor's office. And so CMS has changed that guidance. So be very mindful of that, because if an audit or edit comes up and that claim denies, it's because, once again, something does not match. Okay? And then finally, all of the guidance, and you heard about this morning, we have manuals. They're updated quarterly. Brian makes sure that we turn all of those items in. So make sure that you are reviewing your manuals, that you are looking out for your banner messages, because one of the things that we will do is, once we get all of the official guidance from CMS in terms of what they will and will not allow, we will be holding some webinars. We will make sure that the banner messages come out so that you will know how to bill as a provider. And I know that we'll certainly have some sort of way for you to consistently communicate with us if you have questions. So make sure that you are out there looking at that. And dare I say, Brian, look at your RA. Let's go ahead and say that. Look at your remittance advice, because you will receive that information on there as well. So I'll stop right there, and let's talk about the updates and vaccine treatments that were allowed during the public health emergency and what will continue. Brian?
Hey, everybody. I'm just going to go through this pretty briefly, and then we'll open it up for questions and answered. But we wanted to make sure that as part of this presentation that we had available to you, a listing of all of the codes that were and system updates that were available for antibodies. So we wanted to keep them all in one place so you all were aware of them. And when you go in online, you can look and see, because sometimes I get people who ask me, well, what about this code? What about that code? So we thought it might be helpful for you all to have the information all in one place. We also provide that a third dose is now available, as well as booster shots. I know I've been vaccinated, I don't know how many times, y'all. 3 times, maybe 4 now. I think it's just 3. But that booster shot is also available for specific populations, 18 to 64, and high risk of exposure or otherwise have compromising health conditions. Again, these are the vaccine codes. So you have the Pfizer codes. There's the 1 through 3 in the booster, also the Moderna, and that's it. So mainly this is just to make sure that we keep a public record for you guys of having where all those vaccines and boosters are available. And again, this will be, it actually already is on the GAMIS website if you need it, so that you can have it. All right, everybody, we're going to stop now. I know we're a little ahead of schedule, which is great, and answer any questions, comments, concerns, or otherwise gripes and complaints you may have. Questions? Concerns?
Brian, we have a question.
Okay. Online?
Online.
Great.
Patrick Wood, he asks, how do you tell the difference between member-initiated and provider-initiated?
So we would want some sort of documentation in the record that shows that the member was presenting, as opposed to the situation that what Rebecca was talking about. She's not talking about follow-up calls or anything that is scheduled with the member. The situation she was talking about would be where a provider was actually going down their list and calling members and then billing for a visit when the member hadn't even reached out to the provider. If a member is calling to schedule a visit, if they're making a call for a telehealth visit, if they are initiating the contact, then we would want to see that in some sort of documentation.
Okay.
Anything else?
The second question is, can you list the telehealth exclusions again?
Was that a slide for telehealth decisions? I don't think we specifically had that listed as an exclusion on the slide. I don't remember us having like excluded dental health codes. I mean, for telehealth, they're basically usually part of your Practice Act or more or less common sense things, like you can't draw blood via telehealth, right? It just doesn't make sense. But we've opened the codes broadly for everything else that is commonly via your Practice Acts performed via telehealth. There are some dental codes as well that can be done via telehealth, and then there's some that can't be. Any other questions? Yeah, as well as, thank you, Rebecca, as well as some of the modalities for delivering service.
Are you guys going to continue to pay for COVID testing?
Yes. We haven't made any changes to that.
Ready? Okay, Brian, I have another question online. What parts of telehealth will stay specifically for HCBS?
What parts of telehealth will remain? Did you say will remain?
It says, what parts of telehealth will stay specifically for HCBS?
Yeah, so right now we're looking, we don't know for sure. We have allowed telehealth to exist for some of the case management. We used to have face-to-face requirements in some of the programs, as well as some of the assessment programs. We'll be looking at that based on what CMS guidance is. Our goal is to remain as open with telehealth as possible without violating the Office of Civil Rights exclusions. So anywhere we can keep the telehealth open, we will. But I don't have a specific answer yet because we're still looking through what we're going to keep.
Another question. It says, will providers still be able to work from home after the PHE ends?
So, I mean, we will put out telehealth guidance, and then that telehealth guidance will be able to be followed. And again, a lot of this does hinge on what the Office of Civil Rights says. Because as Rebecca said in her presentation, they did some pretty broad allowances, right? Around things like being able to use a phone, not having to have a secure site for patient records and that sort of thing. So we'll really have to see what happens with the Office of Civil Rights as far as what the future of telehealth will look like.
Okay. Next question. Are there any plans to continue to allow PSS providers to hire family caregivers?
So we did include that in the elderly and disabled waiver? In the elderly and disabled waiver. So that elderly and disabled waiver is under review and renewal right now with CMS to permanently allow for family caregivers in PSS and the elderly and disabled waiver. We did not include that in the ICWP renewal. It is allowable through the public health emergency, and we will look at ICWP past that point. As far as the new options waiver and the comprehensive supports waiver, we will be looking at that at the end of the public health emergency. So we did do it in our proposed renewal for the elderly and disabled waiver, but not the other waivers at this point.
Okay. And can you elaborate relative to case management, POS 02 versus POS 10?
So you would just use the appropriate code for where you were making contact for them at. 02 is 10. Thank you. 02 is everywhere other than the member's home. 10 you use if you are making contact with the member and they are at home.
Says, okay, so exclusions would equal anything that doesn't make sense to provide via telehealth. It's somewhat open to interpretation.
So if that provider has specific questions, they can write me specifically about the codes they are referencing.
Okay. And the last one,
And we will be very specific.
okay. Can we conclude that telehealth will continue after PHE ends?
No, I cannot. So what we've said is that we will look at the Office of Civil Rights guidelines, and we will make sure that we are compliant with the Office of Civil Rights, and we will do what we are committed to as a department is complying with the Office of Civil Rights and broadly allowing as much flexibility as possible to deliver services in a telehealth modality when appropriate under the Office of Civil Rights guidance and appropriate for the service that is indicated. So we will that is absolutely our commitment. Our commitment is to continue telehealth as broadly as possible in the future, as long as it's allowable by the Office of Civil Rights and through the Centers for Medicare and Medicaid Services. But people ask me that all the time. I get calls almost every week where people are like, guarantee me that you won't take away telehealth. And I'm like, I can't do that. A lot of the provisions that happened out of telehealth were very much put in place specific to the public health emergency. I don't know what the Office of Civil Rights is going to come back with as rules. I don't know what CMS is going to come back as rules. So I don't want to overpromise to you that nothing will change, and then the Office of Civil Rights say, hey, you can't do telephonic telehealth anymore, because then we'll have to come back and tell you can't do it. Any other questions? I just want to thank, if not, I want to thank everybody for coming today and for participating online. Your questions are very, very valuable and important to us as we move forward. And reach out to us as necessary. Rebecca and I are always available. Thank you.